The American Rehabilitation Educational Network presents Clinical Update, dedicated to meeting the continuing education needs of rehabilitation and healthcare professionals. Clinical Update is a growing series of informative, useful videotape excerpts from Aaron's monthly video conferences. Applying the talents and expertise of distinguished faculty members from around the world, these programs are specifically designed to provide concise, clinically accurate knowledge for use within the daily practice of physical therapists, occupational therapists, nurses, psychologists, speech pathologists, physicians, and other healthcare professionals. This program, Trunk Mobility and the Components of Normal Gait, features Isabel Bowman and Jan Utley.
Let's begin once again with basic components, and we'll ask you to start us off, Bo.
Okay. The basic components of movement are listed on in your workbook, and one of the ones that we consider foremost is the trunk mobility and control. And when we look at the trunk, we look at, we divide it into two parts, an upper trunk and a lower trunk. The upper trunk we consider as being from the lower rib cage, including the shoulder girdle, the thoracic area, and the muscles that extend up into the neck and head from the shoulder girdle.
Okay. And as we go, Jan is showing us, there's a diagram that's on page 2 in the workbook, and Jan is marking that to coordinate with what you're saying. Okay.
And the lower trunk is considered from the lower rib cage, including the lumbar area and the pelvis. Mm-hmm. And the pelvic movements are very important when you think about the trunk movements, because when we make adjustments, it's the pelvis and the lower trunk area that do most of the moving. And the important movements are an anterior tilt and a posterior tilt. And as we move, we come into an anterior tilt and then go back into a posterior tilt. And we do this frequently. We also move to the side, and when we do that, we come into a slight anterior tilt and then shift to the side. So that those movements are extremely basic to all trunk mobility. Then when you look at the upper trunk, we tend to divide that into two parts, because the shoulder girdles sort of operate separately, one from the other. They don't tend to do the same thing all the time. So we have 4 basic movements that we've talked about so far: anterior, posterior tilt of the pelvis, lateral tilt of the pelvis, and the shoulder girdle separation. Now, if you put those all together, you get what we call a functional rotation, which is the movement that's been emphasized when most people have worked on trunk activities. But we found that by emphasizing the pelvic movements and the lumbar movements, as well as the shoulder girdle separation, we can get much better functional rotation.
Okay.
And those movements are extremely important when you consider any kind of functional activity, because the trunk moves as a base for limb function and head function.
Okay.
When we're sitting or doing standing, the importance in the trunk is to keep the shoulders aligned over the pelvis. And so they're staying, the trunk moves or the pelvis moves, but the shoulders still stay aligned over the pelvis.
Okay.
So that provides the base. Now, when we work on trunk mobility and control, we also consider 2 other basic components of movement, one of which is midline orientation, and that is where we center ourselves over our base. So we put ourselves in the midline, and then we move from the midline in each direction, which is what weight shift is. You move your center of gravity in all directions over your base of support. So you can't really isolate one from the other. They all sort of work together. And that's also true of the head. The head moves separately, but it also has a lot of, what happens in the head very often is dependent upon what's going on in the trunk. If you're sitting in a posterior tilt, your head tends to be slightly forward. If you sit up straight, then the head realigns over the trunk. Or if you shift your weight to the side, the head tends to tilt in the opposite direction. So we call those righting reactions. And the head movements are very much dependent on what's going on in the trunk. And so our emphasis has been more on the trunk, and then assessing what happens with the head in relationship to the trunk. But the head does still have some influence on what the trunk does, because there are some basic reflexes that create patterns in the trunk as well. But the greater influence is what the trunk does to the head. One other factor with the head is that you want to have the independence of moving without the whole trunk moving along with it, so that like you're nodding to me and it's just your head is moving, or I can rotate my head one way or the other, and the whole body doesn't move with it. So that the head has an important role to play, but a lot of it is dependent upon what's happening in the trunk. And then the last component is limb function. And when we look at limb function, we consider both upper limb and lower limb. And both of these limbs do two things primarily. They provide support, so they have a weight-bearing component, and they also are able to move free in space. Developmentally, the weight-bearing component comes first, and then that provides the ability to have skilled, coordinated movement. A normal infant can move, but their movements are not skilled and coordinated, and that doesn't happen until after they've gotten good control in weight bearing. So that in order to have that, you need to have the weight bearing component establishing proximal control and the ability to grade your movements more readily. Now there is one factor in weight bearing on the limbs that you need to consider as well as just the weight bearing, and that is the type of weight bearing that's done in the arm is different from the type of weight bearing that's done in the leg. In order for us to walk, we have to support our full body weight on the lower extremity. Now that's not true with the arm. We support on the arm, but it's not a heavy weight bearing. Occasionally we as adults will lean on an elbow or lean on an extended arm, but we really are not very dynamic when we do that. We just sort of hang on it. That's not what we call good weight bearing. So weight bearing on the upper limb is much more dynamic and light, and you will see that in some of the sequences that we go through later on. But it's an important distinction to remember when you consider weight bearing, that there is a difference between the upper limb and the lower limb.
In fact, all of these basic components become, and their relation to gait becomes crystalline in one of the case studies in particular that we'll be seeing later on.
That's correct.
So I think it's good to keep all of this in mind as we go along.
And you really can't separate one component from the other. They all are important, and we list them in 5 different components, but they don't work in isolation at all.
And Jen, we know that gait also requires an integrated normal postural reflex mechanism. Do you want to just refresh us about that?
Okay. There also is a diagram of this in the workbook.
Yeah.
And since it seems to be fairly self-explanatory, I won't use a pointer. Basically, this is a repertoire of movement patterns that really enable us to function well in relation to gravity. And of course, for normal walking, it's really important to be able to maintain your balance and have good equilibrium reactions. And the base, it works from the bottom up in this diagram. There has to be a range of normal postural tone upon which to function. And that range is a range that we define as high enough to stabilize a person for a stable gait and stay up against gravity. And at the same time, move with ease, because movement is also involved in normal walking. So that range of tone has to be established for a better gait pattern. In development, normal infants go through a stage where they have certain reflexes. These reflexes sort of set the stage for things occurring from more proximal key points. And most of the reflexes, there's one called a tonic neck reflex, asymmetrical tonic neck reflex, which involves movement of the head on something proximally, and something happens in the limbs as a result of that, movement patterns. So those are kind of beginning patterns that set the stage for later, more skilled and coordinated patterns that you see evolving as you look at the riding reactions. And riding reactions basically are reactions that involve the trunk, the upper trunk and lower trunk and the way they move on each other and the separation between the upper and lower trunk. The head and space, optic riding, labyrinthine riding, neck riding, and all of those things tend to keep us more vertically oriented in our environment. Mm-hmm. And of course, all of those things are very important to be integrated in movement patterns that are involved in normal walking. The protective extension and equilibrium reactions basically all are balance types of reactions which have to do with what happens as we move away from the midline and weight shift over a base of support. Protective extension in the limbs involves arm movement and leg movement. It has a weight-bearing component and a movement component, so that if you lose your balance or go to the side, the arms tend to help maintain you by moving out a little away from the trunk. The legs will do the same thing, as we'll see later on. The equilibrium reactions really take us back to the trunk, and they're evaluated primarily by movement patterns in the trunk. As you move over a base, you tend to elongate on the side you're moving toward and shorten on the side you're moving away from. And all of these are integrated and really help in maintaining us for more normal gait patterns.
Okay. And how does normal reciprocal innervation relate to all of these?
That's just a terminology describing the role of the central nervous system in all of these movement patterns, in producing them and coordinating them. And it just indicates that there's control of muscles, which causes a balanced co-contraction around joints, which helps us grade tone to move in these patterns.
Okay. All right. Now, before we can even think about helping a patient who has abnormal gait, we have to fully understand what normal gait is. So let's look at the components of normal gait. What are the key concepts here, Bo?
Well, one of the most important things you need to keep in mind is you want to maintain a symmetrical trunk. And that means that you keep the shoulders aligned over the pelvis. And that's both in the coronal plane and in the sagittal plane. As the weight is shifted from one foot to the other, the shoulders and the pelvis move together, but they stay aligned and symmetrical. And that's extremely important. If the shoulders deviate one way or the other, then you lose the dynamic control on the trunk and you have abnormal movements of the limbs, because the trunk provides the base for limb function. Another important aspect of and a key concept is the weight-bearing surface. You need to have good contact with the plantar surface of the foot on the floor, which stimulates responses in the lower leg and upper leg and in the trunk. And there are some references listed at the back of the workbook that will describe some of that input. But that's a very important input that we sometimes don't consider, and if the patient doesn't have the full foot on the floor, then that's going to interfere with some of those responses. So you have the alignment of the trunk that helps to build better stability in the trunk, plus the input from the contact with the floor that also stimulates input and stability in the leg and the trunk.
Okay. And those are specifically the Duncan articles,
the Duncan
I believe,
articles,
that on
yes.
page 13 with all of the other references. Okay, let's talk first about the stance phase and then about the swing phase, and look at those in a little bit of detail. Jan, do you want to fill us in on the stance phase? What do we need to know about that?
Okay, well, basically, when you look at stance, you want to look at a general alignment of the body. And on the diagrams that you have in the workbook, you can see as the subject is walking toward us, the shoulders basically are aligned over the hips, and you can also see that on the stance side particularly, the shoulders and hips are in a very good alignment over the knee and the foot. And as the person moves forward over the base, from heel strike to mid stance to heel rise, which really characterizes all of the stance phase in gait, there's a grading of tone basically in the extensor muscles and muscle groups generally that help move the person in a coordinated way over the base. And you also need to notice on the front view that there's not a big lateral shift involved in stance. Sometimes we perceive this as being a big shift, but most of the movement is more in a forward direction, so that the movement of the body over the base of support, over the plantar surface of the foot, tends to be more forward, and there's not an appreciable amount of lateral shift for a normal gait speed.
Okay.
I think it's also important to realize that there's a tone quality in the trunk that's critical for a more normal gait pattern and for the control of the lower extremity. And a lot of study has been done in the last few years in this area, and some of those references are also at the back of the workbook. There's a special note about those studies that were done by Thorstenson and some other people, where they looked at the trunk and the role the trunk plays functionally in normal gait patterns. A lot of the studies previously have looked at the lower extremity primarily, and muscle activity in the lower extremity and how that's related to balance and controlling gait. But these people have really started to zero in more on the trunk as being a very important component. And they actually look at it as two phases. They look at a preparatory functional role of the trunk, in which there are certain postural sets in the trunk and tone qualities that are established which cause the lower extremity to be more controlled and to have better stability. And then they look at compensatory functions, that's the ongoing role of the trunk so that you can sustain a tone quality through normal gait. So that they really are now supporting what we've been teaching for a long time about the role of the trunk functionally in normal gait and how important that is for a more normal gait pattern.
So you don't just look at the lower extremities when you're talking about gait. That's a mistake. Right. You want to mention something about how important it is to get past mid-stance.
Yes, that kind of gets us into looking at patients as well as normal subjects in gait. Basically, what happens in patients is a number of things. One is they don't have the ability to sustain a quality of tone throughout the whole phase of stance. You have to maintain a tone quality. They tend to be able to initiate things but not maintain them. So that in the normal gait pattern, this tone quality that grades the extension around the knee and the hip and the movement of the tibia over the foot really enables a normal person to go all the way from heel strike through mid-stance toward heel rise, where the weight is being transferred to the contralateral limb in a very controlled way. And the patients can't grade the tone either with abnormal tone, because the abnormal tone basically interferes with that, so that the movement of the tibia is restricted over the foot. And so patients tend to move toward mid-stance, but they take a very quick step with the uninvolved leg, so they never really get past that point, which kind of holds the whole body back and really doesn't make them very stable. And again, what Bo mentioned about the plantar surface of the foot is really important to realize here. As you move through the whole phase of stance, you really start with a contact on the heel, and progressively through the whole phase, you end up having a fairly total contact on the plantar surface, which stimulates all of those plantar reflexes that Duncan refers to, and actually works from the bottom up as well as working from the trunk down. There's a working from the bottom up because of that complete contact. Well, the patients also lack that ability to really have a good weight-bearing surface, the bottom of the foot, and for a normal gait pattern.
Then your stance phase and gait are compromised.
That's right.
Okay, let's move on then to the swing phase. Bo.
Well, swing phase should really always be preceded by a good stance phase, because that is an important factor in enabling the patient to release the leg, the tone in the leg, to initiate swing. Because at the beginning of swing, there is a release of tone. The trunk muscles release a little bit. It's a graded release, so that the pelvis doesn't drop too much. There's also a release in the leg, so that the knee tends to flex and the foot everts. The knee also tends to fall inward toward midline. So all of those things happen, but it's just sort of a release, a graded release of tone as the individual then brings the leg through. And so there's a minimum amount of flexion in the hip as the leg comes through. They tend to maintain the pattern that we've already established, the knee flexion, the foot eversion, and slight flexion at the hip. And then at the end of swing, you get the extension of the knee, or some extension of the knee. But even at heel strike, the knee is not fully extended. And what happens with patients, they tend to lock the knee. Another thing that patients tend to do is that rather than release the tone in the leg, they elevate the pelvis and rotate it back in order to initiate swing. And that makes them bring the leg through in a very awkward manner with a stiff leg.
Yeah.
So that release is extremely important, and the way that they're enabled to do this is by getting better weight bearing in stance. Now, another factor is important with the swing phase, and that is the patient's stability on the opposite leg. If they don't stand well and stabilize well in the hip on the opposite leg, their pelvis will drop too much on the involved side or the swing side, and then it's difficult for them to bring the leg through. Or some patients will tend to flex both knees in order to get the knee flexed on the swing side. And so they end up, again, not being able to bring the leg through because they've shortened the leg they're standing on. So both of those factors really interfere with their ability to have a good swing. So when you're looking at swing, you have to, as well as the stance, you have to consider the whole body again, the trunk and both legs, as well as what's happening on the swing side.
Okay. Well, now that we are up on the theory of normal gait, let's take a look at it in practice on videotape. And Jan, we're going to ask you to give us a play-by-play as we watch.
Well, you see the subject here walking from the side, and from the side it's easier to look at general alignment first, looking at the shoulders over the hips, and you see that she tends to maintain that. Looking at the stance leg, you see that from heel strike through mid-stance to heel rise, there's a graded tone around the knee and the hip. Arm swing is something that tends to be very natural and more of a passive thing based on the momentum involved in normal gait. In slow motion, it's really interesting to look at because as she walks, you really see the stability of the shoulders over the hips. There's not a lot of malalignment there. And in the leg, you can really begin to appreciate that there is some flexion at the hip and the knee and swing, but not a lot of flexion at the hip. Hers is primarily at the knee, just enough to clear the toe. And toe clearance, you need to see, is not very much. From the front, it's easy to see the components we talked about in swing. When we talked about how at the initiation of swing, the hip tends to drop a little because the trunk has a graded release in tone. You also see that there's not a lot of lateral shift, and in slow motion again, you can really appreciate the confirmation of this, that she really does not shift that much laterally. The movement is actually very much forward over the foot for normal gait. From the back again, just to appreciate that the arm swing is more of a passive thing based on the momentum of the body. The head stays in the midline, shoulders stay over the hips. It's really nice to see.
Okay, thanks, Jan. I know that a couple of people here in the studio audience already have questions, so let's do a mini Q&A with them. Okay, who has a question for Jan or Bo? Okay, here, let me get the mic.
Isabel, we've been taught that pelvic rotation is an important component of gait. How important is that in your mind?
Well, there is a little rotation of the pelvis on a vertical axis, but there is actually more on a horizontal axis. The pelvis drops more than it rotates forward. If you take a long stride, the pelvis will rotate forward more in order to make the stride longer. Or if you're walking extremely fast, you tend to get a lot more rotation on a vertical axis. But for normal speed walking and with not too large steps, there's not a great deal of rotation on a vertical axis.
Okay, so maybe sometimes that gets overemphasized.
Yes, it does.
Okay. All right, any more questions for, okay.
You haven't placed much emphasis on hip and knee flexion. How important are these?
In the swing phase. I assume that's what you're referring to. We traditionally, I can remember placing a lot of emphasis on isolating the activity in the hamstring muscles and the hip flexors to get a patient to actively swing the leg through in that particular phase of gait. But you really need to relate to what you just saw on the videotape with the normal subject walking. First of all, there's really very little hip flexion in swing. It's toward the end, just before heel strike. And it's very slight, and all of the EMG studies that we've always looked at for years have demonstrated that there's not an appreciable amount of muscle activity going on in swing. The subject in the tape had more knee flexion than a lot of subjects will have, but just enough knee flexion to clear the toe for toe clearance. And again, you need to realize that this is something that happens in synergy. It's not something that we can work on in an isolated way either. So that we tend to let that happen more naturally with patients rather than working on it in isolated ways, following a better weight-bearing phase and stance, which really prepares for better tone quality in the flexors and swing.
Okay, any other questions right now? Okay, let me get the mic back to you. Go ahead.
How do you get these components in a patient that has high tone in the lower extremities?
Well, when you have high tone in the lower extremity, we're going to talk about some of the abnormal patterns, but you have to get the release of tone. And one of the ways of doing that, as we discussed in the stance phase, was to enable the person to be able to move over the foot, which tends to help them then release the leg. And so that we'll get into that a little bit more deeply when we talk about the abnormal patterns. But that's essentially what we're trying to do, is to get a good stance so that they can be able to release the leg.
Okay, thanks for all of those questions. We'll take lots more later on. Let's move on now, exactly as you mentioned, Bo, to abnormal tone and patterns. And Jan, we'll ask you to explain just how abnormal tone interferes with normal patterns of gait.
Well, I think the things that we have to remember are, number one, that with a lesion in the central nervous system, there are several abnormal tone problems that begin to interfere with the patient's ability to have more normal gait patterns. They have a loss of movement patterns, which basically means that there's really no memory left of the movement patterns in normal gait. So that those have to be reestablished when you're working with patients. The other thing that happens with the abnormal situation is there are movement patterns that we call associated reactions, which become a problem to the patient. That is, in the lower extremity, the upper extremity, and the trunk, there are abnormal patterns, synergies of movement that tend to come in when a patient is more, welcome back.
Thank you.
She doesn't just reappear here. Magic. But talking about associated reactions,
yeah.
Abnormal patterns of movement that tend to happen and occur when a patient puts more effort into something, when they're more stressed emotionally.
Like getting back onto the riser after you've been in the audience and walking a half a mile to do it.
And
okay.
all of these factors, which are factors really contributing to a lot of problems with gait, because gait is one of the most threatened situations that a patient is in.
Sure.
Because we became bipedal animals instead of quadrupedal animals. We lost a lot of our base of support. So being just on a small plantar surface requires a lot of balance. So these movement patterns really interfere a lot. And as a patient tries to walk faster, these patterns will become worse. So with increased speed, increased effort, increased stress and fear emotionally, they have all sorts of problems with these patterns interfering with normal patterns in gait. Another factor is the tonic reflex activity. The fact that a lot of the reflexes that we had in early infancy become exaggerated and surface with patients. So that whenever they move their head certain ways or move their trunk certain ways, exaggerated patterns tend to happen in the limbs, which really interfere a lot. And a little bit later, I think when the audience is really participating more, you'll really appreciate how some of this begins to feel to normals. Patients also, you know, when you look at tone in hemiplegic patients, you need to realize that they have a mixture of problems.
Yeah.
High tone, low tone, fluctuating tone, and the distribution of tone tends to be spread so that in some areas they're low toned, in some areas they're high toned. Low tone will generally make them much more unstable. High tone will generally make them much stiffer and unable to really be mobile in the trunk or in the lower extremity.
And then fluctuating tone, just throw it in, makes things all the more difficult when that happens.
Yes.
Can you tell us specifically how these kinds of tone problems that you're talking about interfere with the basic components and the normal postural reflex mechanism that we've talked about before, just to tie it in?
Okay. First of all, there's an interference with trunk mobility.
Yeah.
And if you don't have the mobility in the trunk, You will not have the equilibrium reactions that are very useful because you don't have the mobility to elongate when you weight shift and maintain elongation in the trunk. The trunk shortens instead on the weight-bearing side, which makes everything very difficult. The midline is really disrupted a lot because of the imbalance of tone and the high tone contrasted with lower tone, so they really have a great imbalance in tone, which interferes with the trunk. And if you interfere with that, you're going to interfere with everything else, so that the midline is disturbed, the movement over the base is disturbed. Generally, they will do things with their head to compensate for a lot of the tone problems, even if the head isn't directly involved in the tone problem. And of course, the limbs become very directly involved because of all of these associated reactions and very abnormal patterns.
So we're talking about problems, you listed some of them in the workbook as asymmetry, malalignment. And
that's right. There's a lot of asymmetry and malalignment, and then the lack of integration between the two sides is really severely interfered with. That's because the central nervous system is basically a bilaterally functioning system. And the interplay between the two sides of the body for normal gait, Bo already mentioned that we don't only attend to what's happening on the swing side, but what's happening on the stance side simultaneously contributes to what's going on. So the patients lose this interaction. And basically, as an example, tend very often if they're walking and they fall or tend to fall or lose their balance, they lose it to the involved side.
Why is that? That is something that's common.
Which really doesn't make sense, because the normal balance reaction to keep you from falling into gravity should come from the so-called uninvolved side. But because of the disruption in the messages and the integration between the two sides, neither side really functions as it should. And most of the patients will not do the right thing in stance on their uninvolved leg, which interferes to a great extent with swing, as Bo mentioned earlier as well. And the other thing I think that's very important when you look at patients is to realize that we tend to visualize a hemiplegic gait in as being very typical. We all have this picture in our mind of what stroke patients look like when they walk. But I also think it's really important to realize that even with abnormal tone, there's a variety of these abnormal gait patterns, that they're not all exactly the same, that they differ. And you really need to analyze each patient on an individual basis and see how their problems with abnormal tone are interfering with the normal range and normal gait patterns.
Okay, thank you. Now, Bo and Jan, it's time now for our audience to feel for themselves, as promised, exactly what you've been describing. And when we say audience, we do not mean only the studio audience here in Pittsburgh. We really mean everybody at every viewing site. This can truly enhance your understanding, so we ask you all, please do participate. Bo, you want to get us started?
Okay, and I'll call for my volunteer from the audience, Kelly. Worked with Kelly a little bit ahead of time. Now, I'd like to have you all stand up as well. We'll have Kelly face forward. And you need to face a partner, because what you're going to do is to help your partner get into a dynamic posture. Now, what a dynamic alignment, a dynamic posture means that you get the shoulders aligned over the pelvis in both the sagittal and the coronal planes, and that the knees are not locked, so that you are working to maintain this alignment. This is not a relaxed posture, but it is a dynamic one. And with Kelly, you notice that I have to take her out of an anterior tilt, because she tends to stand with an extreme anterior tilt and lock her knees, and make sure that her shoulders are aligned over her pelvis. So you need to do this with your partner, so that you each can get into this posture by yourselves. Another way that you may want to help your partner is to maybe put your hand on the back of the head and ask them to push up against your finger, which will also make you become very dynamic. You just want to make sure that the knees are not locked when you do that. Okay? Now you can all do that? Good. Now face forward again. And I want you to get your feet so that they are directly under your hip joints, which means they won't be more than 4 or 5 inches apart. Your hip joints are sort of in line with the middle of your thigh, not the outside. And you want to get your weight even, but just relax as much as you can in that posture. Because I want you to feel weight shift and taking a step in two different ways. So you're going to shift with a relaxed posture as far as you need to in order to feel the leg that you're moving off of release. Just as soon as the knee starts to bend, you've shifted far enough. So you shift, and then when you feel it release, then take a step with it. And then step back. And feel that just once more. Shift, release, and then take a step. Okay, now get yourself into a very dynamic posture. I'll check Kelly to make sure she's dynamic. And you're going to maintain that as you again shift, and as soon as you feel your knee release, then take a step forward. And try that once more, but stay dynamic. It's important that you maintain that, because what you see, if you have maintained that, and what you feel is that you don't have to shift as far. And as you move, your whole body tends to move over your foot. In the first one, you moved your leg ahead, but you didn't really move over your foot that much. In the second one, you tended to move your body with the shoulders and pelvis, just moving over your foot as you took the same length step, but you're just a lot more dynamic in your movements as well as your posture. And some of you may have felt that you were a little bit lighter. Now that's important for you to feel, because that means that with a dynamic trunk, that you are more stable in your leg on stance. And we keep talking about the dynamic trunk and the alignment of the shoulders over the pelvis, and this is what we mean. You need to really develop that dynamic and co-contraction around the trunk so that the patient can be more stable in the stance leg. Okay, now face your partner. And again, put your feet so that they are underneath your hip joints. And we've talked about the basic components of movement: trunk control, midline, weight shift, head, and limbs. And as you do the activity I'm going to ask you to do, I want you to think about each of these components and what happens in your body as you retract your shoulder girdle. So I'm going to have you retract strongly on one side and feel what happens to your weight, what happens with your midline, feel what happens in your trunk. Now don't hold it a long time. Relax and then go back and do it again, because I don't really want to have to treat all of your shoulder girdles. And if you hold it too long, you may get a muscle spasm. So bring it back strongly, feel a few things, and then relax, okay? Bring it back strongly, and if you felt what's going on in your trunk, then think about what's happening with your arm or your leg. Think about what's happening with your head, and observe your partner, and share that a little bit with your partner. And then we'll talk about it. Now, we'll have Kelly relax again. And as she retracted her shoulder girdle, and as you all retracted your shoulder girdle, what you felt was a weight shift to the other side, right? And you also felt a shortening in your trunk on the side that you retracted. Now, some of you may have felt felt an elongation, but if you did that, you probably elevated your shoulder as you retracted it. And that's what gave you the feeling of elongation. If you weight shifted the other side, you really had to shorten there. The other thing you may have felt or seen on your partner is a rotation back of the pelvis on the same side that you retracted your shoulder girdle. And then what you saw in the arm, go ahead into the retraction again, is some flexion, the beginnings of a flexion pattern. And if you rotated your pelvis back, which most of you did, then you also got an exaggeration of extension, moving the leg into hyperextension. Now, I'm going to have Kelly move back to the platform there, and I want you all to sort of get a little space so you can take a few steps with this. And you're going to walk, holding that retraction. Get yourself into a strongly retracted posture with your shoulder, and then take a few steps forward and back. And we'll have Kelly walk forward on the platform and turn around and walk back. And what you see and what you also feel is the fact that you, first of all, started out with your leg that was retracted because your weight was shifted to the other side. You also didn't stay on that leg as long. You take an uneven step. It's harder to weight bear on that side. Okay? Now, you may have seen that pattern before. I mean, you've got a lot of patients that do that. Okay? So now we're going to try one more. And I'll have Kelly face me again. And you're all going to, you can either face your partner or you can, I think it'll be easier if you face your partner again so you can observe what happens with them as well. And this time, instead of moving your shoulder girdle, you're going to rotate your pelvis back and elevate it on one side. And do that very strongly and feel what happens with your weight. Feel what happens in your trunk. Feel what happens in your leg, in your arm, and in your head. And relax. And again, when you elevated and retracted your pelvis, you got a weight shift to the other side and a shortening in the trunk on the same side. You also found that your shoulder went back. Some of you may have gone into flexion in the arm. Some of you may not have, depending upon how strongly you retracted your shoulder. Some of you may have, well, you all went into strong extension. In fact, what you saw in the leg, do it again, Kelly, is extreme extensor pattern going into plantar flexion and supination with the foot. Then you also need to appreciate that there are some head changes, both with the shoulder girdle retraction and also with the pelvic retraction. When Kelly retracted her shoulder girdle, she rotated her head toward the same side and tilted it that way. And she also tended to do the same thing when she retracted her shoulder girdle. Don't hold that too long. So that there are definite changes in the 5 basic components of movement with just a single pattern. All I asked you to do was to rotate your pelvis back and elevate it, or retract your shoulder girdle. And all of those things happen with your body. So if you've got a patient who has abnormal tone in the shoulder girdle that tends to make them retract, or tends to elevate and retract the pelvis because of high tone in the trunk, or in order to stabilize their pelvis and trunk and hip, then you're going to get all of those changes occurring. Now, I'm going to have Kelly do something that's a lot more difficult. And I'm going to have her walk. And you all can try this too, because I think it's really important for you to feel this. The fact that you want to elevate and retract your pelvis and hold that pattern as you try to walk. Now, it's real difficult to hold the pattern. But I want you to feel this so that you can really appreciate how that makes it difficult for the patient. So Kelly elevates and retracts, shifts to the other side, which means that she has to start out with her involved leg. And you see, it's real hard for her to maintain that, because as soon as she steps, she tends to elongate on that side. The patients won't do that. But she has a very short step. She does great difficulty in weight shifting to that side. She tends to look down because she doesn't feel stable. So that there are a lot of changes that occur. And again, this is a pattern that you've seen with your patients very often. So you really need to look at some of the basic components and whether the patient has the stability or the mobility to be able to do what you're asking them to do, rather than just asking them to walk through a pattern like that. It's very difficult. And it's something that you all hopefully have gotten a better feel for now, because it really interferes a lot with your ability to function. Thank you, Kelly.
Okay, now we've discussed abnormal tone and we've experienced abnormal tone and patterns. Now let's see on videotape how these kinds of problems interfere with the gait of a patient named Don. Jan, once again, we'll ask you to comment as we go along.
Okay, we'll first be looking at Don walking straight away from us and then back toward us. I think the main thing to look at first is the general alignment. You can see that he tends to shift the shoulders over to the left in an extreme. He doesn't even keep his left shoulder over his left hip well. The right shoulder and right hip, you don't see a lot of separation in the trunk on his right side. He stays shortened on that side. He doesn't stay on the foot, the involved leg, for very long. He makes a very quick step with the uninvolved leg. You also notice how difficult a turn is. And turning is a very important part of functional gait, and all of the patients have a lot of trouble with that. I think it's also important to see that the associated reactions in the arm are a real problem. And as he walks and continues to walk, the tone becomes higher in the arm. He also does exactly what Kelly did. He looks down almost the whole time as he walks. As he turns to walk back, you also needed to realize that his cane and his left leg really become his primary bases of support. So he really is shifted where the line of gravity almost falls between the cane and the left leg. So he's not really able to put much weight at all laterally on the right leg. He also tends to circumduct the leg just a little bit as he comes through. Now, he's going to come back once more toward us. You also need to appreciate what you just felt when you walked this way, how the tone felt. And here's a man that walks this way and can't really get any normal patterns, so he has that increased tone the whole time, all day, for as long as he walks. And it tends to become more exaggerated in some places as he walks. Now he's going to walk without his cane. And as you will see, all of his problems become much more exaggerated without the cane. I think it's interesting to see that he's lost part of his base, actually, when he doesn't use his cane. What he had in his left arm before is no longer there. So he's really having a lot of problems. He doesn't get the leg through as well on the right. He really shifts in an exaggerated way the shoulders to the left. He shortens more on the right side of the trunk, elevates the pelvis. The arm is much stiffer. The foot supinates a little bit, and his step is very, very fast with the left leg. As he turns, he even has more difficulty with the turn functionally than he did with the cane as well. His balance reactions are also very exaggerated in the left arm. He really has to stop and kind of regroup before he continues to walk toward us again. And as he walks toward us this time, you can see the total rotation back on the right side of his body. And it really becomes more exaggerated the longer he walks. Now from the side, he takes a minute to start to walk here. As he starts to walk, you really can look and appreciate, again, the rotation back on the right side. How the head is forward and down. He's looking down. Even though his stride length is not appreciably that different, you can see how he circumducts the right leg to bring it through, and he doesn't stay on the left leg for very long. Also elevates the pelvis, and you can really see as he walks this direction how swaying is interfered with a lot on the involved leg. The beginning of swaying, he elevates instead of releases, so it just causes the whole pattern to start to come in as he walks. The circumduction, the supination in the foot, and the kind of surging of the body.
This concludes the clinical update presentation of trunk mobility and the components of normal gait, which featured Isabel Bowman and Jan Utley. For more information about clinical update or any of Aaron's educational programs, call or write the American Rehabilitation Educational Network